We want to empower the patient. We want to tell them that they are the captain of their ship, so they need to pick a really strong crew that can help them, that knows the disease process. So they need to let you know what their problems are. You need to accurately assess literally their strengths and weaknesses, their spasticity. You need to know that if they have a urinary tract infection, back off. If they are coming out of an exacerbation, how hard you can push them or not. You need to also be able to accurately assist them with assistive devices, with the Bioness, with braces. You need to be familiar with the medications that they are on for spasticity and UTIs and disease-modifying therapies. You have to be a tremendous source of advocacy for them. Of course, they need to be quite involved in their own care. They lean on you tremendously to be their point of contact. Related to spasticity, one of the huge problems of many that persons with MS are confronted with. The therapists are able to accurately assess the spasticity, and sometimes we can work with it. If you have a lot of muscle weakness as a patient, it may not be great to get rid of all spasticity, because the spasticity in the hamstrings, the quads, the glutes, etc., may be helping the patient to transfer, to stand upright. We can work with passive range of motion stretching, instruct patients in active assistive or active range of motion, strengthening exercises if they do have some strength that can be built upon. But spasticity can be a two-edged sword, so it needs to be accurately assessed, accurately treated by a therapist, a healthcare team member that knows MS. We want a physician assistant, nurse practitioner to refer the patient to us immediately. That information we gather from the very beginning is crucial to dealing with a patient, especially long-term. We as rehab team members want to maximize the patient's functional abilities, maximize the quality of their life, keep them as strong as possible. First, of course, identifying strengths and weaknesses, problem areas, and modifying and building upon the strengths, combating the weaknesses to the best of our ability through hands-on, through exercise, through assistive devices, any way that we can help these patients. As a physical therapist, we need to work hand in hand with the entire healthcare team. Not every patient needs every single rehab specialist out there, but the physical therapist may be the one to identify, I think you need speech. Maybe not for your language problems. You may have perfect speech, but you may need to see a speech therapist or an occupational therapist for some cognitive retraining and a cognitive assessment. Patients with MS have some problems with executive functioning. Speech and OT are excellent for that area. They may need to be referred to a urologist, speech, OT, PT, vocation counseling. Everybody should be seen by physical therapy, occupational therapy, etc., as soon as they are diagnosed. It's crucial. Even if you are not having a lot of symptoms then, if you're in a period of remission, we need to see you to assess you then, get a baseline, whether it's accurate or whether you're weaker than normal because you're just coming out of an exacerbation, or whether you're doing really well because you're in remission. So we work with not only the here and now that we see of you, but we want to help you be able to plan for the future. Put you on a strengthening program or a cardiovascular program to use and be modified down the road. And that way, when you do run into problems, or on the flip side of the coin, we will see patients who are doing better. So they might come back to me, I'm a physical therapist, and say, Sue, I'm doing really well. This stuff is too easy for me. Or I no longer need the walker. What can I switch to? So being assessed and reassessed is very, very important. So seeing us right off the bat is very crucial. The referral should come from your physician, physician assistant, nurse practitioner. There are some states that have laws that allow direct access, so a patient can go in off the street to a physical therapist and ask to be treated. And that varies state to state. With the frequency that we are seeing patients and the relationship sometimes very close that we develop with these patients, they may reveal things to us that we are responsible for being able to refer them, such as problems with bowel and bladder, sexual dysfunction, anxiety, depression, vocational difficulties that they are having. We need to be the touch point to refer them to the appropriate other healthcare providers. They may need to contact the physician to request a referral to one of the other healthcare professionals, and it may be an area that the patient didn't even realize they have a deficit in, or that particular healthcare professional is even available. A lot of people just don't know the options that are out there for them. Persons with MS often deal with bowel and bladder dysfunction. This can obviously be very detrimental to daily life. It can incredibly inhibit them in their mobility. It can definitely interfere with their ability to exercise. It's going to be really difficult to get out somewhere. Also, a healthcare team member has to recognize signs of a urinary tract infection and how detrimental that can be, how it needs to be treated immediately. And there's also an area in physical therapy, it's women's health, and they can deal with problems that help incontinence. It can even help males, but there are treatments available. Some require pharmacological intervention. Some can be muscular and positional help from the physical therapist. Urinary tract infection can be very, very detrimental, set someone back quite a bit. And even if the person just has chronic problems with incontinence, need to go frequently, they can again receive some physical therapy help, consult the physician for medication, or a referral to a urologist. So regarding bladder issues, there are therapists who deal with incontinence and frequency and urgency. There are therapists who specialize in women's health issues. Interventions can be hands-on. It takes a special therapist to know what to do. There can be home activities that the person may need to do, such as stopping, voiding midstream 8-10 times per time that they empty their bladder. And then a male with problems with incontinence, frequency, urgency can also seek help through the MD, through the urologist, and find what is available for him. There's a tremendous difference between an acute bladder infection, urinary tract infection, versus just the regular run-of-the-mill incontinence, frequency, and urgency. The frequency, urgency, that is very, very common with MS, which can be dealt with. The urinary tract infection, bladder infection are acute problems. It is an infection. That has to be treated quickly, usually with medication. You as a therapist need to accurately assess how often are they falling, how is their gait, how far are they able to walk. The world of MS has many, many standardized tests for us professionals, and I'll speak to OT. The National MS Society has the tests, the standardized tests that we can do with patients very easily in a clinical setting, sometimes a home environment, that will give us accurate information. There's a Berg balance test. We can assess their risk of falls. I really like to emphasize to patients and therapists how important it is to decrease the incidence of falls. A simple fall might result in a fractured wrist, a broken ankle. Worst case scenarios, surgery, pins, plates, casts. inactivity for 6 or 8 weeks, then several months of therapy to get back to where they were, and that's not even including the MS. So decreasing the incidence of falls is extremely important. Patients can find some programs that are 6 and 8 weeks long that work with therapists and lecturers, that say through the National MS Society or your local hospital organization, that sponsor these programs, and they do show that they can definitely decrease the incidence of falls and the severity of falls. As a therapist, we also want to deal with and show patients that if you fall, what's a good way to fall if possible? How do you get up from a fall? How can your healthcare provider how can your support partner who's home with you help to get you up without harming themselves? And we have techniques, based on physics and positioning to make these transitions easier, so you don't have to call the EMTs every time you may fall. So very, very, very important to maximize our knowledge as therapists for helping patients with the activities of daily living. And PTs and OTs are masters of that. The awareness of devices for safety is very, very important for therapists and patients. Apple just came out with a new watch that can notify somebody, loved one, caretaker, etc., if a patient has fallen. Also, the little fob that is worn around the neck, that if you are conscious and you fall, you can hit that and notify people that you need help. So these are crucial to making sure that you remain safe, or that the patient remains safe, that the necessary care is going to be on its way, versus a patient lying on the floor, not found for several days or several hours, and that can be very, very detrimental to their health. Depression is a huge problem with persons with MS. That is proven time and time again through numerous studies. Exercise lessens depression. That is proven time and time again since the 70s. The amount of clinical research just verifying that continues to skyrocket. Put those two things together, exercise can definitely help decrease depression amongst persons with MS. Not only do they feel better, there are obvious terrific health benefits: cardiovascular, strength, flexibility, balance and coordination benefits with exercises. Of course, the exercise program needs to be fine-tuned to that specific patient's needs. But exercise is, it's a must in the program for a patient with MS, for their wellness, for their self-efficacy, which is having the patient feel better about their life, about the control that they have over their life, feel better about themselves. At this point in time in the world of MS, almost all patients should be on a disease-modifying medication. The physical therapist may have some input back to the patient, how they see the medication affecting the patient over time. The patient may only see the physician every 6 months or every year. If we're seeing them once a week or 3 times a week for a long period of time, we may be the first ones noticing that, they're having this bad reaction, or this over a year just does not seem to be doing the trick. It's up to us to contact the referring physician to let the patient know that my professional opinion is this is not working that well for you, or it may be affecting you adversely. So the therapists need to be very familiar with the medications that are out there for treating persons with MS and the course of the disease. So the disease-modifying meds, you need to be aware of what they are, what they do, the positive reactions they should see in a patient, the negative reactions that may occur. We are the front line often with patients. We may see them weekly, 3 times a week for several weeks. If they are an inpatient patient of ours, we're going to be seeing them daily. So we see them much more often than they will see their physician, physician assistant, nurse practitioner. So we're going to be able to monitor how they're doing, how the medication may be affecting them, and a variety of medications have a variety of positive effects, some negative side effects. If we are doing exercises with a person and we notice that they are having some urine leakage, we may be the first ones to notice that. The patient with decreased sensation may not even notice it. They may be dry by the time they get home. So we are often the conduit to the other healthcare team in noticing some small patient problems and progression of the disease. So regarding a number of secondary complications that a patient may encounter with MS, the list is long. So we want to keep in mind orthopedic problems, the asymmetry that is involved regarding MS. Weakness on one side and tightness, full strength on the other side results in very asymmetrical gait patterns. It can result in sitting in a wheelchair, very uneven. It can result in skin breakdown, low back pain, either from long sitting or walking improperly, having the wrong assistive device prescribed to you. Or how many people do we know say, oh, this was my husband's cane, so I'm using it. It's the wrong height. It's on the wrong side. They may be in a type of ankle-foot orthosis that is 15 years old and weighs several pounds. They don't know the new advancements in orthotics and prosthetics that are available. They may not be privy to what is out there. I really like working with people with MS. They are one of the most receptive groups. They are usually engaged in their well-being. It's problem solving. We are looking at the patient as a whole. We are helping them be the captain of their ship. We are part of their crew, and they are so appreciative. And I don't want to say their needs are great, because not everyone's need is great for all the therapies. But what they do need, and we are able to help them with, it's extremely rewarding seeing them do well. I sort of fell into MS years ago. I was working in a VA hospital. One of the patients that I had with MS asked if I would start to help with volunteering on a National MS Society committee. Did that. Loved it, met wonderful professionals and patients through that. That led to working with what used to be the Jimmy Hugus Center, then the Hugus Center, Can Do MS. Extremely involved in patient education in hands-on multidisciplinary programs. Led to affiliations with the MS World, great organization for online and in-person education, and home care, yoga. I've been a yoga instructor for quite a few years. I love incorporating yoga with treatment of MS patients, or just purely teaching yoga to persons with MS. So it's really interwoven in my life and in my friendships, personally, professionally,